urologist and robotic surgeon, pediatric urologist and minimally invasive urologist working at Yashoda Hospitals. He did MS from PGI Chandigarh and MCH DNB Urology. He's a fellow European Board of Urology. He was from the Citizens Hospital, Hyderabad, India. He is the governing council member of Dr. YSR University of Health Sciences, Vijayawada, Andhra Pradesh. He is the past president, Association of Southern Urologists, 2021 to 22. He was invited to moderate session on ureteric reimplantation in Turkish Pediatric Urology Centenary Celebrations and SPUS. He is the invited speaker to Cincinnati Children's Hospital, USA 2016. He is a faculty to live operative workshops on minimally invasive surgery, formerly professor and head of the Department of Urology, Narayana Medical College, faculty and examiner of postdoctoral fellowship of pediatric urology, KLE University, Belgaum. He has around 51 publications till date and 5 book chapters on his name, and he is the editor-in-chief of the Journal of Association of Southern Urologists. He is invited to be the editor of Pediatric Urology Section, USI Textbook of Urology. He is the national mentor for Robotic Surgery and Pediatric Urological Society, Robotics Department, and he has wrote the chapter on Pediatric Lapiloplasty in Children in UCNA, Feb 2015. Over to you, sir.
Okay. Thank you very much, Soundarya. Thank you, Pure Urology. You may have to stop sharing, Soundarya.
Yes, sir. Yes, I'm doing this.
I thank Chandramohan and Pure Urology for giving me this opportunity. We all are very aware about the minimal invasive strategies in BPH. I'll just take you just as an introduction that what all we have in today. There are a plethora of things which have really come up. Then we are not very sure what to do, what not to do. Now, all of us are aware about Urolift, the regime, which is the steam injection. We know aqua ablation still has not come much seriously into India, but it's being done, which is actually robotically controlled, which we don't do anything, that we feed the data onto the aqua ablation machine and then it starts ablating the whole prostate. The balloons, the other one which is not written here is the ITIN, which actually is a device which actually opens up into the prostate and then which is removed after about 3 to 6 weeks, if I'm not wrong. And then you always know that the thulium, the holmium, and the bipolar, and the standard TURP. So, of all these things, we also have to add a prostatic artery embolization, which is caught up on a lot of promotional activity from the interventional radiologists and some cardiologists who are actually doing regularly the interventional vascular work. Now, let me get through a little more of prostatic artery embolization and to know why this is probably important. Now, this has also come up into the guidelines of EUA and also AUA, that there are specific indications that in prostatic bleed, in large prostates, in patients with about 60-70 gram prostates, where they would like to have all the functions of ejaculation, then this is an option which you can exercise. So people are going gaga in trying to do something of a prostatic artery embolization. Now, I will get on to that a little more. This was one of the MemoCap stents, or the self-expanding thermoluminal stents, which we did implant in an elderly gentleman who was very high risk for surgery because of his restrictive cardiomyopathy status. And then see that the stent is going in. This is all that stent, the rings of the stent, and then we are deploying the stent exactly there. And once you put in, you push in a saline at 60 degrees. Now, what that does is you can see the rings of the stent. At 60 degrees, the stents tend to expand, and then the sheath comes out for us. And then you will be able to see the rings nicely sitting and opening the prostate. Now, these stents can also be removed if in case they are causing a problem that you just need to inject ice cold water. It would shrink, and then you can actually pull it out as a string. For some reason, because of its non-patronage, this has not been now, it's been discontinued, and not very well available around the world also. After all the Eurolift and all, I think the stents are going into oblivion. But these are ones which they are salvageable in patients who don't have large median lobes and then who have lateral lobes. So we do have a lot of things which are going on. Now you will see the stent. We will not go with the cystoscope across the stent, and neither we put a catheter. So this is how the stent opens up. And then you can nicely see the sphincter there. So once we get into a minimal invasive scenarios, we need to pick and choose the patient very appropriately. So what is happening with prostatic artery embolization? And then before I get into case details, I'll probably give you a little just why I embarked on this particular area of treatment. All of us know that we are the ones who would see a patient with prostate with all the symptoms. Now, once we see the prostate, we evaluate the particular gentleman, and then we'll see whether he would need medications or he would need surgery or probably biomedia, some medication. So we have a plethora of options which are going on. And then the days of internet where the patients are extremely net savvy come up. And then suddenly someone comes up and then tells us, sir, what about prostatic artery embolization? But the big problem comes here is you just because you're not doing it, and then someone else is doing it, you'll tell them that no, it's not very effective. Not so. This guy very well understands that you are not the guy who is doing it. So the guy who is doing it is pushing the envelope, saying that, oh no, it's a great panacea. Everyone will become normal. No one will need surgery. It's just a daycare procedure or just a minimal sedation. All those things which go on. And then I've had anecdotal reports of even rectal necrosis and penile necrosis because of inappropriately done prostatic artery embolizations with the coils. So, where do you stand? Now, if you look at people like us, probably we have about 10 more years of work to go on. But then if I have a larger vision about urology, I see that every year about 450 to 500 young urologists are added to the pool of urology in India. Now, with the expanding pool of urologists, we need to expand our areas of urology. Rather, if we start at least consolidating what we have today, I think tomorrow we will leave certain areas to our younger generation. So this was one major thing why I started doing the prostatic embolization myself. I let you know what was a lot of people would be wondering that is it really that is it that it's very difficult, only few people can do it? I think it's just the mindset. I will just get you people across the mindset. So let's get into a little more science rather than the semantics, and then let's see two cases which we have done three. I will present you two of them. This was a 68-year-old male with LUTs. He had a 113-gram gland with a poor flow. So we did offer him the options of embolization, the laser for him. So we told him that the embolization may not be fully effective. And in case it's not fully effective, then probably you would end up getting a laser done. So So once we the access is through the right femoral. The access has to be around the femoral head. The reason why you need to have the access onto the femoral artery at the femoral head is because you need to compress the artery after you remove the sheath. You put in a 6 French sheath here, and through that goes in a 6 French guide. These are guiding catheters. You can use uh, uh, you can use a the renal catheter, or you can use a RCA, or the right coronary artery catheters. So these are needed depending on how do you like to cannulate the internal iliac, the opposite internal iliac versus the ipsilateral internal iliac. So you need to keep these, the renal, and the RCAs, and you can also use a J-tip. So this was the Euroflow of that particular individual. It's not, I'm not very sure how clear it is, but the flow was poor and then definitely needed an intervention. So once you get into that, you put in this catheter, and then now what happened now, then I'll just get back a little more and then see. Now that is a micro catheter. That's a 2.5 French micro catheter. You can see a larger 6 French catheter. Here, we have gone in across, we've gone cannulated the left internal iliac, and then got into the prostatic artery here. You will have this branch, which will give out a few of the perineal branches, and along with that, this is the prostatic artery, which is going here. So sometimes you may need to really, now you see that we had actually embolization, another one which would be much more clearer, that you see that this branch is lost here, and the PVP beads are placed. Now again here, you see a lot of things. Don't look at the YouTube. I would probably present the best of my details into the YouTube. So this is also a small artery which was there, and then I think I'll show you again. This going all across this, and then the beads would be placed, and then you will see that this little twig which was there is gone. Now, that guy is voiding better. He has improved. I would need to get in the flows subsequently, because just about 1.5 months. You just wait for 2 months before we do it. This was actually the first case which we did. So it's a 64-year-old male, had an 80 cc prostate. We did a standard workup. We did a bipolar TUR. He was discharged on day 3. And then lo and behold, he develops an MI on day 4. So there's no question that he needed a primary angioplasty. And then a stenting was performed. And then he starts bleeding. So we had 3 episodes of clot retentions, which we had to do clot evacuation irrigation in that week, and then the bleed would not stop. We gave him SDPs. We had everything to do, and then there was no way that we could stop the bleed, because every time when we did a clot evacuation, we went in and saw there was nothing which we could do except try to coagulate the surface, and then it would bleed. So there, now you can see that, sorry. Now you can see that this is the 6 French catheter. This is a J-tape actually, which has gone in, and we have cannulated the internal iliac. Now, once you cannulate the internal iliac, you get this roadmap. You can see that the posterior branch going the gluteal. This is the anterior branch. And then this is the prostatic vessel, which actually hooks up like a lateral anterior. Now, once then you put in a microcatheter, you get microcatheters which are 2.5 or 2.7, 1.5 French. So, sorry. So this is called a run through. So this is what this cardiologist used to go through the coronaries in a very narrow. And this tip here you can bend it. You can actually have a needle and then bend it across. You can bend it to whatever angle you want. You want a 30-degree or a 60 or a 90. So this is a floppy tip guide wire where you can bend the tip. And once this goes, you then thread this microcatheter across. Once you have the microcatheter in place, you see that this is going up, which is actually getting into a little of the superior vesical arteries. Now, once you get the microcatheter here, you do the angiogram, and you can see a small blush, a small AV malformation sort of thing on the prostate, which was actually causing that bleed. And then uh, now that we have given PVP beads with the, I'll show you again. So these are the PVP beads which are put in along with some contrast. These beads, about 150 to 250 microns, these block this catheter, sorry, this vessel. So now you see that there is no blood flow going into that blush. So once that was done, and fortunately, today I had the same guy coming to me for a follow-up. So he's absolutely fine. So now you go on to the opposite side. Now this is the difficult part. This is where you probably need a right coronary because the internal iliac, ipsilateral internal iliac accessing that is difficult because you just have to hook it. And once you hook it, the guide wire goes. This is actually a termo. What you're using is a termo. Once you go through the termo, the hook catheter gets into the internal iliac. Then you put in a run through, and over it you thread the microcatheter. So there is a very small atretic catheter. The small atretic vessel here, which we embolize, and I'm just showing you what we use in the during the embolization. So these are the micro PVP particles. You get 250, 355, you get 350, 500, you get 150, 250. So it all depends on what you would like at that point, depending on the vessel. Use the larger ones, it would not go into the vessel if they get into some of the microcirculations. So you need to see the vessel. So these are the paraphernalia which we will need to use during the prostatic artery embolization. So now at this point, I would like to get to all of you that what we are using there or doing there is puncturing the femoral artery at the femoral head at a 45-degree angle with a 18 gauge needle. You can use an ultrasound and then do it. You get blood, put in a guide wire, a J-tip guide wire. They all use a J-tip because they don't want a dissection in any of these vessels. Put in the nicely thread in the sheath. Again, put in a J-tip termo through that, put in the access catheter, and then start working around. And all those things are the termos. These are the ones which we are being using day in, day out, and every day. And once we know that how difficult it is to go through a ureteric stricture, this is far simpler. So let's not worry that, oh, only someone can do. We did not. How can we do? And how do we get trained? There is no worry about training. Let me assure you, all of you, if anyone is keen on doing it, I'll come and assist you for a case or so. It is only assistance because you're all good surgeons. You can actually go through everything. And then you will be able to do it on your own. I just need to come only to get your mind blocked so that you can do it. So taking this into a larger area of urology, uh, if you're all aware that with the AI, every physician without intervention is really worried that their jobs may be really cut through with an AI. And I feel that their jobs will be very difficult over the next 5 years. So the nephrologists have started talking about interventional nephrology, where they have started doing fistulas, there they are doing percutaneous CAPDs, they are doing fistula angiograms. Then they've also talked about that the pyelonephritis gets admitted with them and they wanted to learn cystoscopy to place stents. So now see where they are going. They're also talking about onconephrology, where they are talking that they will take care of those nephrons in case of malignancies, where even in other malignancies, just not renal malignancies. So they are trying to expand into areas hitherto unknown. The pediatric surgeons are trying to get into pediatric andrology. A lot of people would laugh if we talk about pediatric andrology. But when I've spoken to our colleagues of pediatric urology in US, they say that the sexuality starts at 8 years of age. And they are talking about the fertility preservation in cryptorchidism and all that, and they want to create one area of pediatric andrology, then the varicoceles in children. So if we start losing out on areas in urology, I think the next generation would lose out significantly. There are people who are overtly putting out advertisements of prostatic artery embolizations. I am looking at a larger area in urology where you can look at an endovascular interventions or an endovascular urology, where a lot of us have had an experience of leading to embolization of a pseudoaneurysm because of a PCNL or any other thing. I have had one pseudoaneurysm in the kidney, which I embolized around 2019 post RIRS. We can need to do tumor embolizations. We need to go back and then start doing percutaneous renal artery stentings and angioplasties. The newer area which actually we can go in is to do pudendal artery angioplasties in impotence. We need to do a good CT pelvic angio to see what it is. And then if there are segmental narrowings and the rest vessels are normal, we can do a pudendal embolizations. I've seen a guy who had a trauma and had a bleed, had a bulbar artery coiled in UK. Varicocele embolizations have not really gained that prominence because they have not given that result of improving the fertility. But then this would come in soon in terms of at least in the pain and other areas that people would start doing more. And maybe with these particles rather than the coils, they may now go down where near the inguinal ring and above, just above the testes, and then go. The fistulas are the ones which we are losing out. We need to push. I think this edition of our JASO will have an article on fistula. There's so many areas of fistula interventions where we need to do if there are mid-segment narrowing of the vein. So we can always do an angioplasty, which is very, very, very simple. So it's a mindset. The day in and all of us now. If I ask you as a urologist, what are you? You have no idea what you are. The reason why I am saying that is if I have to choose one surgeon, if there's a CT surgeon, there's a neurosurgeon, a urologist, a gastrosurgeon, and a pediatric surgeon, I would choose a urologist for the simple reason that the urologist can handle abdomen, thorax, when you do thoracoabdominal incisions, retroperitoneum, pelvis, vascular surgery. When you have so much of talent, you just have to apply your just little mind and then get over the inhibition that you could do this little prostatic embolization. Let people not take it over. It's a very simple procedure. In your hands, the indications would be perfect. No one would do something abnormal and then put that particular procedure to disrepute the way which things are going on now. So in our hands, we will be doing the appropriate things. The past may not be our fault. The future will be if we just leave it like that. And then the day is not far that if we start crying, there's no one who's going to help us. And then this is what we'll have to do. We'll be just drowning and then just be happy to take a selfie and post it before we drown. The end of the day, you achieve nothing, but then you have lost out on everything. Thank you very much for your attention. And then Chandramohan, Pure Urology, Thank you again for this opportunity. We did one before on the robotic transplants, and then what more can I say? Thank you again.
Sir, sorry, sir.
You are actually a little.
South permit.
You're not clear, Chandramohan, please.
Hello, Sundarya.
Sir, your voice is not clear, sir. It's
Hello.
breaking.
Hello.
Yes, sir.
No, they were
Yes,
actually.
it will take just 10 seconds time. It will take 10 seconds. It will come. Soundarya, you like to continue the discussion before my voice is clear? Is it clear?
Yes, sir. I have a few
Better,
questions.
better, Chandramohan.
Can I?
Yeah.
So, sir, what is the gland range, size of the gland range, which would be suitable or which will be not be suitable for prostatic artery embolization, sir?
Anything beyond 60 is suitable today.
Okay, sir. So
60 grams. So below that, they say it's not suitable. But anything beyond 60 is suitable. But then again, you'll have to choose the right patient.
So after embolization, how many days in general can we expect the results or symptom relief?
2 to 3 months.
2 to 3 months. So till that time, if a patient is already on catheter, do you think he has to continue catheter after the procedure for 2 to 3 months?
Yes, he needs to continue on catheter. But this is one other indication where the people who are on long-term catheters who are not candidates for intervention in terms because they're probably high risk for anesthesia. So these are the people who would again benefit, but it's okay if they have been long-term catheter, give them an option for about 1 or 2 months more, and then we can get their catheter. So it is not going to be immediately effective.
So in advanced malignancies, channel TRB where we are doing, in those patients also, is it an option, sir?
That has not been studied yet, Soundarya. That's not been studied yet. And we haven't, neither I have also tried doing that. Maybe one day I think I'll take your cue in terms of someone who had a large CA prostate and who thinks that if he's not very keen on surgery, then he wants an option. Probably can be given, but I'm not very sure because whether it would have multiple blood vessels from elsewhere,
yes,
which would probably not allow the gland to regress.
So in patients with recurrent urinary infections who are already having multiple long-term catheterization, history of frequent catheter blocks with a lot of debris in the bladder, so will they be candidates or are there any other contraindications for prostatic artery embolization?
I don't think there are any specific contraindications rather than the specific indications. The contraindications would be if you have bad pelvic vessels. Recently, we did on one international patient. His external iliac was so tortuous that we had to actually use a very long sheath to traverse the tortuosity. Otherwise, the guide catheter was actually coiling around and then it was bending there. So technical issues would be there. But as you said, if someone with recurrent UTIs and then a long-term catheter, I think they're perfect candidates for infection. Is not a contraindication to do angiography per se, but you need to cover them with appropriate antibiotics and then go ahead. That would not stop you from doing this procedure. But the very small gland, it's not going to be effective.
So before taking up for the procedure, do you assess how do you assess the pelvic vasculature? Do you do Doppler or any pelvic?
We don't assess anything here because
decision.
Yeah, it's only an on-table decision. There has been a discussion on whether we should do a pelvic CT angiography. Now, this procedure would add to 2 episodes of contrast. So, generally, when we are looking at embolization, we would like to go straight ahead. I would give a caveat to the patient that sometimes we may have an atretic vessel on one side and then one side we may be not doing well. Very rarely what happens is you can actually dissect the internal iliac. If you dissect the internal iliac, you should abandon the procedure because that side would have blocked everything. The opposite side, if you actually dissect, then you will have a problem that there can be rectal necrosis because the middle rectal artery on both sides come from the internal iliac and then it can the collaterals are not going to be effective. The second thing would be penile necrosis. So you, by chance, you dissect one side, you have to abandon. So this is a caveat we always tell them, that there could be an atretic vessel. Sometimes they may abandon these procedures. Either way, even if you're looking at a laser, if you're doing anything, so we are looking at some sort of a situation where very rarely that we may say that we may not be able to complete the procedure for some reason.
Yes.
So these are the issues which can happen with the embolization.
So after successfully completing the procedure, have you ever had recurrence? Like there was another neovascularization which was coming up, so it got failed. So what is the success rate of the procedure in general, sir?
In general, the success rate would be somewhere about 80% or so in terms of, look, the gland size would not really greatly decrease. It would decrease by about 20-25%. But because it actually, the transition zone tends to regress, you would tend to have a little more better flows, and then all the advantages of the regression of the transitional zone. Whether it would come back, no one knows in the world at this point, because I don't think we have that kind of follow-up after post embolization, that whether it would come back, because an atrophic gland may not develop angiogenesis again. But if there has been a de novo malignancy, which I think that probably there would be an increase. But once the gland atrophies, I don't think it would develop de novo angiogenesis to grow again. So that, I think, should give this a fairly long-lasting relief to the patient once it is effective.
Thank you, sir.
Okay. Am I audible, Soundarya?
Yes, sir, you're audible. Voice is clear, sir.
Yeah. So, thank you, Mallikarjuna Reddy, sir. I also have some few questions. Though I was first 5 minutes, I was not there.
Nothing much, I was stimulating all our younger fellows to take up full urology rather than leaving urology.
You are always emotional about pediatric study. That's why how you
your voice is breaking.
Hello. You are always everything. You are always emotional about pediatric surgery also. I also agree. And you have taken to the next level, especially after forming the pediatric surgery subdivision. All the people like Ansari sir, all of you are taking this into front line. It is very good thing. When somebody see, it's a as your last slide is very important. Taking the selfie before death is of no value. You should have knowledge. And the only thing is, this is angioembolization can be done in corporate hospital. When did you do first attempt of this embolization, angio attempt, sir? When did you do first? Soundarya, can I continue the discussion, please, with your permission?
Yes, sir. Yes, sir. Please.
Yeah, please.
Yeah, my first attempt at angiography was in 2001. Yeah,
when you are in Nellore?
Nellore. Why did I do
that? What was the reason you learned?
Reason, I had to do a tumor embolization. I had a tumor and I thought it's a big tumor, so I thought that it would be...
That time, did cardiologist help you?
Cardiologist created hurdles. I said, who are you to create hurdles? You are the fellows who can't handle your own complications. You should not do that. After all, putting one guide wire and putting a catheter into a renal artery and pushing some gel foam, do I need that fellow? So I started doing it. I did that. Then he said, no. Then the management said, no, you can't use the cath lab once. I said, get lost. So we started doing it under CM. Then I realized that it was very difficult to do a flush angiogram because the pressure inside the aorta is somewhere about 240. You really need to be a robust guy to push in and do a flush aortogram. But then the selective renal artery was much more simpler. Then
control of the guide wire
even taught the neurologist how to do a 4-vessel angiography. The whole issue is a mindset, gentlemen. You are an accomplished surgeon. Can't you puncture an artery and put a guide wire and put a sheath and then go across? You have to apply your mind, isn't it?
Yeah. That means it can be under CM also. The difficulty under CM is
you will not have the images which are being played.
Okay.
So that
The
and the
basic mechanism,
roadmaps would not be easy. So it is
sir,
difficult.
basic mechanism of the guide wire movement will be outside, sir. Like outside it is rotating.
Yeah, what happens is with the fine guide wire, there is called a small rotator, which we should buy, I think, if we have to do something inside the kidney rarely.
Yeah,
Okay,
that's what I'm thinking. Whether this guide wire rotation will be useful in the ureter to move
correct.
like this.
So I can show you the rotator later. Right? So there is a small rotator which goes onto the guide wire and just gets fixed. Then you can actually rotate the guide wire.
And in between, you will be keep on injecting contrast. How much contrast will be used, sir, roughly?
We use about 80 ml to 100 ml of contrast. Takes about
Okay.
1 hour or so, 1 to
And
one and
these
a half
gel
hours.
forms, how much they cost?
It's not gel form. They are PVP microparticles. One costs about 12,500.
How many you require generally for in
One or
PCNL?
two.
And see, why I am discussing, already 100 people have joined. They
Yeah.
also have interest.
No, Chandramohan. I have all the time in the world to discuss.
The question I am asking is, the embolization is more useful for the urologist when there is PCNL bleeding.
Correct.
Urologist can accompany and try to see and then get acquainted. All may not be skilled like you to do, but we love to know that catheter, once you keep in the renal artery aneurysm part, when you embolize, what are the material which are cost effective. For example, in districts, urology will do the PCNL, it may bleed. In Hyderabad, for example, I have one Venkateshwarlu, he is also radiologist. He is not cardiologist. So
Yes.
cardiologist, radiologist, both can, then we also can do. There is no problem. He puts a lower cost, some metal or something. And usually he starts with his experience. He's around 6 years. So, do you have idea about the materials which how to load them into the catheter and how to push them through the syringe?
Yes. Look, I'll tell you the materials. Look, in larger catheters, larger vessels, where we were trying to embolize the tumors, we were using gel foam. The reason why we were using gel foam, you can actually powder the gel foam, mix it with the contrast, and then inject. Now, those were being injected through a 5 French or a 4 French catheters. So those used to go, and they are never permanent. They get dissolved, and over a period of time, you will have again the blood flow going through. So then came the scenarios where we needed permanent materials. So people used alcohol in tumors where they could actually destroy the arteries. But the problem with alcohol was there was a little ooze back into the aorta, and then it used to cause aortic stenosis, and then you got severe reactions. Now, what we do when we use it for any of these pseudo aneurysms in a kidney, you can use a fine coils which you get. There are different kinds of coils. There are little straight coils, and then those coils are not very costly. They're about 25,000 at this point of time. You may need 1 or 2 coils to embolize the vessel in the kidney. As a prostate is concerned, we don't use coils because most of these vessels are very, very small, the prostatic vessels. You've done so many of these radical prostates. In spite of those big prostates, the vessel is around 1 and a half mm. So when you're looking at 2.5 French catheter, which is almost 1 mm, 3 French should be 1 mm. So you just, when in that, if you are trying to put a coil through that, it would sit in an area where there is a branch, and that branch is the pudendal. So that is where you and I have heard about penile necrosis, because once you put in a coil, the amount of coagulation across the coil is significant, both proximally and distally. So in prostate, we're not putting coils, we're using this PVP beads. Now, based on the size of the artery, if the catheter wedges very, very difficult with a difficulty onto the artery, we use a finer particles of 150 to 250. If it goes nicely into the artery, we use somewhere about 250 to 350 microns. Now, the cost of this is the one vial would cost you somewhere about 12,500. Most of the particles are the same thing. It all depends that the maximum you would use probably 2 vials. You just have to mix it in a 2 cc syringe and then mix it with saline or with contrast. Generally, we are not mixing with contrast because they are staying in the artery and then we are not able to see whether our embolization is good or not. The first time we mixed with the contrast, but subsequently we are only just injecting the PVP, then giving a contrast so that we know that that particular vessels are blocked. So basically, these are not very costly. Now the standard catheters which they are using for cardiac and all that, they are reused umpteen number of times. So the sheets and all, they're all reused.
Okay. So that's something interesting and very nice that you have explored a new area, and we didn't know that you have done in way back in 10 years back. Good, sir. And indications are there definitely related to the urology. If anytime next time we will come and watch you also, if at all any case is there. Obviously, I also feel that if the radiologists are doing embolization for the prostate, then indications will change. It's not a good sign. Do you agree, Soundarya?
Yes, sir.
Indication should be decided by the urologist and only urologist. In that way, I appreciate your daringness. We know for your daring surgeries successfully and decisions also. Really appreciate your enthusiasm, sir. Thank you very much for enlightening. Yes, sir.
I'll just take about 2-3 more minutes with your
Yes, sir.
permission.
Yes, sir.
Look, the point is, everyone, I presented this at Jalandhar, then the South Zone, then I'm now speaking on it at the North Zone wanted to me to speak on the areas where you can expand in terms of vascular urology. What I try, people ask me, are you trained or are you trained to do it? Are you legally okay to do it? I don't think there is anything legality today. How is that someone who is legal, someone who does a radiology, who gets to train to put a small guide wire, gets into the prostate and then starts doing the prostate? He doesn't know anything about LUTs, he doesn't know anything about prostate, he doesn't know anything about the bladder, and he just wants to do an intervention. I think a barber can also do that intervention. That's number one. So there is no legality. You want to learn? I think this world today gives everyone the opportunities to learn. But you have to have the aptitude to learn. That's what the reason why I would have really said that I will do a workshop or I will probably do a training program. I am not very keen on doing that for the simple reason that if I do a training program, people will come see, I said they clap and then they say everything and then they'll go. But I'm more than happy to travel to anyone who is willing to spend his nighttime oil, take a cath lab option, go in the evening, see all what you want. I'll come. The reason why I'm saying I'll come, I don't need anything. Neither even in my airfare, I will come on my own. My intention is to train 10 people in this in our country in this 1 year so that they will go up and then they train. The only reason why I say I'll come is to get their inhibitions off. Anyone is very, very open. Please call me, please message me, do whatever you want. And it doesn't cost as much.
Understood, sir. Understood. That is
I'll be there. One case you do, you're all accomplished urologists, very good surgeons. One case you do. After that, you will do it yourself. You know where to stop, where not to stop.
Okay, sir. Thank you. Thank you very much, sir. That is a good this thing. It's a new opening in the field of the urology, and that's great initiative. I appreciate that. A lot of audience, more than 120 now, have watched the program. Wish you will contribute to the Pure in future with more pediatric urology and any important surgeries.
Always with you, Chandraman. Anytime.
Yes, thank you. Thank you very much.
Thank you very much.
Thank you, Soundarya, for the.
Thank you.
Thank you, sir. Soundarya.